Right. Good evening, everyone. A very warm and hearty welcome. This is your host and moderator, Arjun Mahajan. I represent JMitra, and we're very glad to have you on board with us today for our panel discussion on the subject of hepatitis B, a clinical and diagnostic perspective. I'm very happy to announce that we have some acclaimed medical practitioners with us today, including Dr. Zubair Hasan, Dr. K.T. Sangeeta, and Dr. Manismita Biswas Agarwal will be joining us very shortly. Now, a short introduction to them that, collectively we've got Dr. Zubair Hasan, who's a pathologist, Dr. Sangeeta, who's a microbiologist, and Dr. Manismita, who is an anesthesiologist. Between the three of them, they've got over 35 to 40 years of experience. And I think that puts the presentations for today, the discussions for today in a different light. Each of them has their own specialty and will be taking up the pathogenesis, the epidemiology, the treatment, the diagnosis of the disease of the virus, which is hepatitis B. Hepatitis B is something that is, it's a sexually transmitted disease, of course, as everyone knows, but it sometimes remains an underwhelming disease. It does not get the requisite amount of attention, which is why we have this panel, illustrious panel today, which will share their views and on the subject matter at hand. With that, I would like to, can I request Dr. Zubair Hasan to take us forward through this? Right, Dr. Hasan, you have the, I believe I've given the sharing rights. You can share your screen and, take us through these. Let's get started while Dr. Biswas joins us.
Yeah, can you see my screen now?
Yes, so we can see the screen. You can.
Right. Very good evening to everybody. First of all, I thank you, JMitra, for having me here in this August forum. I will try my level best to do justification to this topic. Right. First of all, a disclaimer: I am no authority. Right. It's a big topic, and a lot of people have done a lot of work. And in this short span of 10 to 15 minutes, I will just try to give a brief overview about epidemiology and pathogenesis. Right. Many things most of us will know, but we will go through it in a very simplified manner, hopefully. So, a little bit about hepatitis B virus. So, it is a global public health problem. There is no denying that, right? There are an estimated 350 million HBV carriers in the world, of whom 1 million die annually. With diseases. Some references have placed the number of affected as much as 5% of the total world population. That's quite a lot, right? Now, if you look at the WHO figures, it says 90% of people living with viral hepatitis are unaware that they have it. So just imagine the magnitude that people are not aware that they have it. So that's something mind-boggling, right? So let me just move this bar a little down. Yeah. So the spectrum of clinical manifestation of HBV infection varies in both acute and chronic diseases. During the acute phase, manifestations range from subclinical hepatitis to fulminant hepatitis. And during the chronic phase, manifestations range from an asymptomatic carrier state to cirrhosis and hepatocellular carcinoma. So it is not one disease. The presentation is quite variable. Many people are asymptomatic, while some go for even the dreaded carcinomas. Now, what is this hepatitis virus? More of it will be told in detail by our microbiologist of the panel, but it is a virus belonging to the family of HepaDNA viruses. The genome of HBV is a relaxed, circular, partially double-stranded DNA of approximately 3,200 base pairs in length. It's a very small DNA actually, right? And the complete virion or the Dane particle is as much as about 42 nanometers in diameter. Now, integration of the HBV DNA into the host genome is not necessary for viral synthesis. Means the HBV transcripts are synthesized from the episomal DNA. It's one DNA lying outside the main nucleus, right? it is where the synthesis happens. And in addition to the intact virions, HBV-infected hepatocytes contain a subviral particle. What is this subviral particle? It is a kind of an immunogenic material. It's 20 nanometer spheres, long filamentous protein, and they are not infectious because they do not contain the viral DNA, but they generate immunity. And this was the property that was exploited while generating the first HBV vaccine. And we really do not know what these subviral particles actually play a role in the life cycle. So if we look at this, this is the virions, HBV virions, the viral particles, and these are the subviral particles which I just mentioned, which cause the immunogenicity and create the vaccine. Coming to the thing, the epidemiology. So globally, estimated 240 million people are chronically infected with HIV. If we talk of our own country, it is about 4.2%, with over 40 million HBV carriers. Just imagine, out of the 100 people around you, 3 or 4 maybe hepatitis B carriers. It's a big number. And every year, 1,15,000 people are dying out of hepatitis B complications. It's something to think about, isn't it? And there are 10 known HBV genotypes, A to J. D is the most common, followed by A and C. So, coming to this infection, about 40% of these patients, all right, of the chronic HBV go for hepatocellular carcinoma, and 20 to 30% cases die are of cirrhosis in India. And who are these people? They are mostly recipients of multiple blood or blood product transfusion, patients on hemodialysis, those who inject drugs, female sexual workers, sexual partners of infected people, prisoners, migrants, and truckers. And a high-risk population for viral hepatitis includes close first-degree relatives and family members, mothers, siblings, spouse, children of people affected with viral hepatitis, the first-degree relatives as well. Important thing is the perinatal transmission, the transmission from the mother to the child, right? That is also a very important thing to look at. And 60% become infected by the age of 5 years. So sometimes what happens is at birth, the baby is not having hepatitis B. But after some time, though infected, but it manifests at a later age. That also is quite possible, right? So even with active and passive immunization, 5 to 10% of babies may acquire HBV infection at birth. That's why very important to immunize them at birth itself. In United States and Western Europe, injected drug use remains a very important mode of HBV transmission, up to 23% of all cases. Now, a little bit about pathogenesis. I do not want to overburden all the genes and all that. There's a lot of work happening, right? And as I said, I'm not the authority to speak about the genetics and all that. But yes, what we need to understand is, just like when we talk about HIV, we talk about the cell-mediated immunity. We talk about the T lymphocytes. The same way, hepatitis B viral infection as well, it plays a role. In what way? It is related to the cytotoxic T-cell mediated lysis of the infected hepatocytes. So there is a level of immunity. The immune response of each individual determines whether a patient will go for fulminant hepatitis or chronic hepatitis or active hepatitis, right? We have to remember that. The virus is not behaving differently. It is the immune response generated. One example of it I will give again with the familiar COVID-19 virus. COVID-19 also we used to see, right? Majority were asymptomatic, but one or two people would end up with the ICU and they would just pass away, right? With the complication, same way. It is similar to that. Most of the viruses behave that way. So majority are asymptomatic, but few of them will go for fulminant hepatitis. So patients with chronic hepatitis B virus who clear the HBe antigen. So the next speaker will speak more in detail about the different antigens on the virus, right? So those who clear the HBe antigen and have a vigorous cytotoxic T lymphocyte response to HBV antigens are those who remain HBe positive. So HBe positivity was related with chronic hepatitis B. That was one study finding. In one study, HBV specific cytotoxic T cells removed from the patients tested after 23 years still showed some amount of activity, okay, indicating they had the activation markers. So that means the virus does not disappear completely, even though a patient may be negative after hepatitis. That is not a full stop, it's a comma. It can recur again. The patient can again go for an active flare-up, right? That has to be remembered. This observation suggests that complete eradication of HBV rarely occurs after recovery from acute hepatitis, and that traces of the virus can maintain the T cell response for decades following clinical recovery, which in turn keeps the virus under control. So as I told someone who has got the virus negative today, yeah, good, but then we do not know, right? Again, it will flare up in the future. So the maximal reduction in the HBV DNA levels have occurred prior to peak in the increase in serum ALT levels, suggesting that the viral control is mediated through non-cytolytic as well as cytolytic mechanisms. And HBV in general is not a cytopathic virus, does not per se destroy the cells alone. However, direct cytopathic liver injury can also occur if the viral load is very high in certain patients. In most patients with chronic hepatitis B, for example, there is no direct correlation between the viral load and the severity of liver disease. I'm asking you again, why? Why is it? Because as I told you, it is not the viral load that is causing the severity of the virus. It is the immune response and susceptibility of an individual. Or we can say the immune status of an individual that is responsible for the response. So again, a complicated diagram, we see this, we get overwhelmed, right? So viral particles, what are they doing? They're getting into the nucleus. And we have something called a cccDNA, triple C DNA, covalently closed circular DNA. This undergoes a transcription followed by a translation and leads to formation of viral particles which move out of the cell, and it makes sure it recycles again, right? So this triple C DNA estimation, people have tried estimating it. They have tried estimating, but they found it's difficult to estimate because each cell has a variable amount of triple C DNA in it, right? But it remains important for a cure, and the cure can only happen if we understand the pathogenesis of the disease. So coming to a little bit about the spectrum of the diseases, first we have the acute HBV infection. So in primary infection, HBsAg becomes detectable after an incubation period of 4 to 10 weeks, followed shortly by antibodies against the HBV core antigen. How does it manifest? It will manifest, it's not necessary that there should be jaundice, right? We all have that misconception because I have counseled many of my colleagues, my medical workers who had hepatitis B positive, and they said, no, we never had a history of jaundice earlier. So it's not necessary that jaundice will manifest in the acute HBV infection. It can manifest as a serum sickness-like syndrome during the prodromal period, followed by constitutional symptoms like what? Anorexia. Anorexia means don't feel like eating, nausea, jaundice, and right upper quadrant discomfort. Viremia is well established by the time HBsAg is detected, and the titers of the virus in acute infection are very high, frequently 10 to the power 9 to 10 to the power 10 virions per ml. When liver injury occurs in primary infection, ALT levels do not increase until after viral infection is well established, reflecting the time required to generate the T cell mediated immune response that triggers the liver injury. So here, just like how we speak about HIV, T cell response and all that, here also T cell response is important, right? A lot of papers have been done on this topic. And values up to 1000 to 2000 international units per liter are typically seen during the acute phase, with ALT being higher than AST. With the clearance of infection, the viral antigens HBsAg, HBeAg disappear from the circulation and free anti-HBs antibodies become detectable. And in patients who recover, normalization of serum aminotransfers usually occur within 1 to 4 months. Approximately 70% of patients with acute hepatitis B have subclinical or anictic hepatitis. They do not have jaundice. They don't get a misconception they have jaundice. They have anictic hepatitis, while 30% develop icteric hepatitis. And the disease may become more severe in patients co-infected with other hepatitis viruses or with underlying liver disease. And when do you say it's chronic? When the ALT level, when the HBsAg is positive for more than 6 months. It goes for chronic hepatitis. So persistent elevation of serum ALT for more than 6 months indicates chronic hepatitis, and the rate of progression from acute to chronic hepatitis is primarily determined by the age of the infection. Coming to fulminant hepatitis, the most feared complication of acute HBV is fulminant hepatitis, very drastic hepatitis. It is with hepatic encephalopathy, within 8 weeks of the onset of symptoms, and the prognosis is poor once encephalopathy has developed. I am just telling you broadly. The next speaker, she may give in much more detail about the practical aspects of the Manasita here in this panel discussion. Right? She will give her practical discussion experience as well. And the fulminant hepatitis is unusual, occurring in approximately 0.1 to 0.5% of patients, and believed to be due to immune-mediated lysis of the infected hepatocytes. Right? So chronic hepatitis is when, as I told you, and the viremia or the HBsAg antigen is detectable for a period of 6 months or more, And one feature that is widely not appreciated, which I have highlighted in bits and pieces, is the dynamic natural history. It can go from an active phase to a quiescent phase and again become active, right? And what determines it? The viral replication and the host immune response. So as I said, I told my colleague, that many of them may not have an acute hepatitis history, but they will just be HbA positive, and it will be very surprising to know that. So let's just see some statistics. The risk of developing chronic HBV infection after acute exposure is about 90% in newborns of HBe antigen positive mothers and 25 to 30% in infants, while in children under 5 and less than 10% in adults. Meaning to say, at birth, if they are newborns are there who are positive for HBCG, 90% chance they will go for chronic hepatitis. And if the age of diagnosis is under 5 years, there is 25 to 30% chance that they will go for chronic hepatitis. If it is diagnosed newly in adults, 10% chance that they will go for chronic hepatitis. And many patients with chronic hepatitis, they are asymptomatic, as I mentioned already, and you will have to monitor them with the aminotransferase levels. All right, and a liver biopsy may be done. Not many prefer it though, right? And just a little bit of histopathology, being a pathologist myself. So in acute hepatitis B infection, we will have a lobular disarray with ballooning degeneration, multiple apoptotic bodies, Kupffer cell activation, and lymphocyte predominant lobular and portal inflammation. In chronic hepatitis B infection, we will have a lymphocyte predominant portal inflammation with interface hepatitis and spotty lobular inflammation. There are these different terms, and I think it's beyond the scope to make you understand all these terms, right? So for my session, over to the next speaker with a few thoughts that hepatitis B virus infection continues to be a global public health problem. And I would like to emphasize by saying understanding the role of this CCC DNA in HBV maintenance, learning about the CCC DNA formation, its transcriptional regulation, turnover, and intracellular stability will be fundamental to find a cure. Thank you, and over to the next speaker.
Thank you, Dr. Hasan. That was very informative. A good starting point, as I would say, and definitely well covered when you talked about epidemiology and the basics of hepatitis B to get people started thinking. The aim of our webinars here is to open up a debate, open up a point of discussion. That things are not always what they seem, and there is something coming up ahead in terms of product development, in terms of disease diagnosis, and maybe even a mutation of the disease virus per se. So keeping that in mind, I think we would like to talk to Dr. Sangeeta now, talking about the diagnosis, right, Doctor?
Yes.
Yeah. So you can share
your. Yeah. Is the screen visible?
Perfectly visible, ma'am. Please go ahead.
Yeah. Thank you, Dr. Zubair, for the extensive presentation on the epidemiology and the pathogenesis. So to go ahead, let's start with the lab diagnosis of hepatitis B. So first, before that, we need to know what is the structure. So this is a circular form, as a spherical virus, an envelope virus around 42 nanometer. So we need to know, in order to know the diagnosis, what we are going to diagnose. So we need to know the structure of the virus. So coming to the structure, you can see here it's an envelope virus. That is the antigen which is present. That is a surface antigen. That is a HBsAg antigen. And then inside that we have the nucleocapsid, which has the hepatitis B, that is the core antigen it is called. And in between these two, we have a pre-core antigen, which is known as the HBe antigen, that is the envelope antigen. Now, inside the nucleocapsid, what we have is that an incomplete double-stranded DNA with a DNA polymerase. So this is, in general, the structure of hepatitis B virus. It is a DNA virus belonging to the family Hepatnaviridae. So as you understand, the hepatitis, the surface antigen, the core antigen, and in between that, we have the pre-core antigen, that is HBe antigen. And this is a HBV DNA, and this is a DNA polymerase. So now coming to the what WHO says. Most of it I'll be talking from the guidelines WHO which is set up for hepatitis B testing, that is 2017 guidelines. So So here WHO says about the various categories which need to be tested. When it comes to the general population, in a setting with a prevalence of more than 2 to 5%, all adults have an access to HPV serological testing. So in India, you take up the various studies, we have a prevalence around 3 to 8%. So obviously all the adults have an access to HPV serological testing. When it comes to focus testing, we usually test in adults and adolescents from population who are most affected by HPV infection, like in those populations where the prevalence is very high, like the migrants or prisoners or those who are drug addicts. It was previously discussed in the previous talk, and who are with a history of exposure, let it be sexual exposure or blood transfusions, or with people with some high risk behaviors, even adults and children with a clinical suspicion of chronic viral hepatitis, sexual partners, children, and other family members who are living with a person with HPV. Coming to the pregnant population, in a setting with a seroprevalence of more than 2 to 5%, WHO recommends routine testing of pregnant women for HPV infection. Blood donor screening, in all settings, all donors have to be screened for HPV infection. Now let's see what are the various markers which are available for hepatitis B testing. So we have various antigens, antibody, and the nucleic acid, the molecular markers. The antigens, what we detect, that is a HBS. I have already discussed that is a surface antigen which is present on the envelope. So this is the most commonly used antigen which is used for detecting hepatitis B virus. Next is the hepatitis core antigen. This antigen, it is not secreted, so that is why it does not appear in the blood. So this is not used for diagnosis of hepatitis B. Next is the pre-core antigen, which I mentioned, that is a HBe antigen. This can be detected in the serum. Coming to the antibody, so we have HBS, so we have an anti-HBS, it's a neutralizing antibody. Though HBC doesn't appear, it doesn't get secreted, we have antibodies developed to that, that is IgM, and one more is a combination of IgM and IgG, which we call as total anti-HBC. And also we have antibodies against the HBe, that is a pre-core antigen, which is known as the anti-HBe antibody. And coming to the molecular markers, the HBV DNA can be detected. There are various assays which are, some are qualitative, some are quantitative. So I'll be discussing that in detail. Now, coming to the diagnosis of the serological markers, we have various platforms available. So first, I'll be discussing regarding the rapid diagnostic test. So when we look into the rapid diagnostic test, we have the various Hepacards available, which are based on immunochromatography method or lateral flow assays. So the rapid diagnostic test, they can detect HBsAg, that is a surface antigen. That can be performed either on serum, plasma, or whole blood. They have a pool sensitivity of more than 90% and a specificity more than 98%. Compared to the laboratory methods, which uses enzyme immunoassays as the reference standard. Again, the sensitivity varies widely overall and within each brand of hepatitis antigen. Now, next coming to the serological assays, they are the various little more advanced than the rapid diagnostics with better sensitivities. They are the ELISA platforms. And now we have newer technologies like the electrochemiluminescence immunoassay, microparticle enzyme immunoassay, and the chemiluminescent microparticle immunoassays. So these have better sensitivities compared to the rapid diagnostic test. Next will be the latest, that is a nucleic acid amplification techniques. Again, various platforms are available. The three different types of amplification techniques are target amplification, signal amplification, and probe amplification. Again, these tests are having higher sensitivities. So coming to the target amplification, the most commonly used ones are the polymerase chain reaction. We also have some isothermal based amplification, that is nucleic acid sequence based amplification, transcription mediated amplification, strand displacement amplification. But still the most commonly used ones are PCR. So here you can see the different systems or the different platforms which are available from various companies, and the sensitivity or the limit of detection of these assays. They can detect from 1 to 1.5 log international unit per ml of the hepatitis B virus DNA. So now coming to the different markers and how do you clinically interpret these markers in various courses of hepatitis B infection. So when we take the first marker, I told you the most commonly used marker being the hepatitis B, that is a surface antigen. So this is the first marker to appear following HBV infection. Actually, it occurs even in the incubation period, almost 2 to 6 weeks before you have a rise in your liver enzymes or even the clinical symptoms. It occurs nearly 2 to 6 weeks prior to an elevated liver enzymes. Its positivity indicates the presence of the virus in a person's body, that is, a person is infective. Acute infection, the HBsAg antigen disappears within 6 months. If suppose the HBsAg antigen persists beyond 6 months or more than 6 months, we tell it as a chronic infection, where it persists for several years. Then coming to the antibody to HBs antigen, that is anti-HBs, which we call, it is actually a neutralizing antibody, and its presence confirms that the patient is cured, protection from infection. It usually appears after the clearance of acute infection, that is after HBsAg. The anti-HBs antibodies they develop, and they are known as the neutralizing antibodies, and they confer actually protection from infection. And they do not or does not develop in those who have chronic infection. They also develop in response to hepatitis B vaccine. The vaccine is mainly targeted against the surface antigen, so the antibodies are anti-HBs. So they also are seen in after vaccination. Their presence indicates immunity following acute infection or vaccination. Anti-HBs titer of more than 10 milli-international unit per ml is considered to be protective. It persists for several years, often lifelong after infection, but disappears in a few years after immunization. Now, next coming to the hepatitis B core antigen and antibody. So the core antigen, I have already discussed that it is not secreted. So that is why it does not appear in the infected person's blood. It is present only in the nucleus of the infected cells, so that it is not tested in the clinical settings. Now coming to anti-HBC, it develops in almost all those who get HBV infection, whether let it be chronic or acute. It does not develop after immunization. And there are two types of IgM and IgG. So coming to IgM anti-HBC, it actually appears following acute infection and persists for up to nearly 6 months. Hence, their presence indicates recent or an acute infection. Sometimes they are detectable in low amount even during severe exacerbation of chronic infection. But usually it is a marker of a recent infection, and it appears nearly 1 to 2 weeks after the appearance of the HBs antigen, and it can persist for up to 6 months. Next is the IgG, or we call it, or the total anti-HBC, what we call it, combines IgM and IgG. So the total anti-HBC or IgG, it develops soon after IgM anti-HBC. It's a most constant marker of exposure. It indicates current or a past infection. It's positive total anti-HBC with a negative IgM anti-HBC. In a hepatitis, HBs AG antigen negative indicates a resolved infection. So again, to stress on the point, if we have a total anti-HBC along with HBsAg antigen and the patient is symptomatic with elevated liver enzymes, it is a chronic stage. Whereas if there is presence of IgG anti-HBC along with the persistence of HBsAg antigen, but the patient is not symptomatic, it is a carrier state. And if we have the presence of IgG anti-HBC along with anti-HBs, that means the patient has recovered from the infection. Now coming to HBe antigen, it is usually produced in cells where the virus is actively replicating and secreted into the plasma. Usually its presence indicates actually a high viral load and high infectivity. Its absence again indicates a lower viral load, lower HBV DNA level, associated with a high risk of HBV transmission following exposure, such as needle stick injury or mother to child transmission. Now coming to the antibody against HBe antigen, this indicates actually host immune response against HBe antigen. It is usually associated with a reduced viral replication, lower HBV DNA titer, and reduced infectivity. Now coming to HBV DNA, it's actually a direct and accurate marker of HBV replication. The serum level seems to correlate with the risk of disease progression, used to decide mainly the HBV DNA. It is actually used to decide the need for antiviral drugs, and also it is used to monitor the efficacy of the antiviral drug treatment. So usually the standard which is we diagnose, that is usually given as IU per ml, the HBV DNA level through various molecular assays. So now when we take the course of acute HB, the hepatitis B infection, it's a picture which shows what is the course of all the markers in acute infection. So you can see here, as I said, the HBS antigen is the first marker to appear. It appears within 1 to 12 weeks of infection. So the first marker, it usually increases within 2 to 10 weeks. It appears a peak and then it gradually disappears by around 6 months. The next I said was the IgM, even the HBE antigen also, and also the IgM anti-HBC. So IgM anti-HBC, again, it rises and then it drops down by around 32 weeks. Next is that is a total anti-HBC, that is IgM plus IgG. This total anti-HBC, it remains almost positive throughout the life. Thus, the total anti-HBC is actually a marker of past infection. Now you can see here HBE antigen, and then slowly this also converts to anti-HBE antigen. Now you can see here by 6 months we have the HBS in an acute infection. You can see here the hepatitis, that is a surface antigen, it drops down by around 24 weeks. And then it takes nearly a small gap for the anti-HBS to develop. So this gap is nothing but the window period. As we have in HIV also, this is a gap where there is the disappearance of the antigen, and before the appearance of anti-HBS and antibody, we have a gap. This is known as a window period. And during this window period, if you want to detect, this is the IgM anti-HBC, which can be detected during this window period. So after that, you can see here, after nearly 32 weeks, we have the anti-HBS, that is a neutralizing antibody development. In this phase, you can see that the patient will be cured of the acute infection. So here, when we take a clinical interpretation of what are the various markers and how will you diagnose with each phase. So you can see here, this is a phase where we have the HBS antigen positive, HBE antigen positive, and IgM anti-HBC with plus or minus the total anti-HBC. With high level of hepatitis B viral DNA, your liver enzymes are increased. So this is a case where it is as it is IgM anti-HBC, we have, this is a early acute infection. Now next, I discussed about the window period. So the window period is a time when we have the disappearance of the HBS antigen. So here the HBS antigen is not there, HBE antigen is not there. You have the IgM anti-HBC, which can be detected during the window period. The total can be plus or minus, and you have the DNA levels and also increased liver enzymes. So this is a period what we call it as a window period. Next is a situation where you can see the recovery phase where HBS antigen has disappeared, HBE antigen has disappeared, there is no IgM anti-HBC, the IgG will be positive here, so that's why the total anti-HBC is positive. We have the neutralizing antibodies developing, that is anti-HBS, and we have again HBE has disappeared, and now we have the appearance of anti-HBE, and here the levels are little plus or minus of DNA, and we have the liver enzymes also normal. So this is known as the recovery phase from acute infection. So after giving this one about the acute infection, now let's go into the chronic infection phase. So here again, you can see this is acute, and this is the acute which is progressing towards chronic. Okay, so here you can see, I said the basic definition of a chronic infection: if the hepatitis B surface antigen persists beyond 6 months, the phase it is said to be going into chronic infection. So here, obviously, the HBsAg antigen you can see here. So basically, in this, the HBs antigen and the total anti-HBC, it continues to remain positive. So these two are very good markers when it comes to chronic. But again, you need to even different phases in chronic are there. So we need to have more markers to get in details of the chronic infection. Now, I said about IgM anti-HBC, it's more commonly seen in recent or acute infection. But sometimes in some cases of chronic infection, IgM anti-HBC becomes positive with low level associated with hepatitis flare. Then hepatitis antigen, it may wane over time as age increases, usually in elderly population. Now let's see how to diagnose in each phase of chronic hepatitis B infection. So we have the chronic hepatitis B, the different phases, that is the immunotolerant phase, the immune active phase, the inactive phase, and this is a reactivation phase. So in immune tolerant phase, we can see this phase where you have a high level of HBV DNA levels, whereas the enzymes are normal. Here the infection is at its peak, but the host immune response has not started acting. So that's why the liver is not yet damaged. So that is why this is a phase where we have HPS antigen persisting more than 6 months, is almost chronic infection. So here we have a positive HPS antigen. This is a phase where immunotolerant, where the HBE antigen remains positive. So HBE antigen, and in a chronic phase, you can see a gradual decrease, conversion of HBE antigen to HBE antibody. Whereas in acute, there is a rapid shift from HBE antigen to anti-HBE antibody. Whereas here, there is a gradual decrease. So this is a immunotolerant phase where we have HBE antigen. And then IgM, this is, since this is a chronic infection, IgM is not there. IgG or IgM, that is a total anti-HBC, remains positive. It's an indicator of chronic infection. Again, antibodies have not developed. Anti-HBS is almost a neutralizing, so that will not be there. Anti-HBE has not developed yet. There is a high DNA levels and normal or slightly increased the liver enzymes. So this phase is known as the immunotolerant phase. Now, next we go to the immune active phase, where now what is happening? The enzymes are becoming more, the DNA levels are going on fluctuating. And this is a phase where the immune response has started setting in. So there is obviously liver damage and the enzymes have started rising up. So this is a phase which is, you have hepatitis B surface antigen present, HBE antigen present. Again, IgM will not be there as it is a chronic infection. The total anti-HBC will remain positive. Then again, we have the DNA levels again high and increased liver enzymes. This is known as immune active phase. Next, one more immune active phase where the progression of HBE has started converting to anti-HBE. So in such a case, there will be HBS antigen positive, HBE antigen has converted to anti-HBS, anti-HBE. Again, we have the presence of total anti-HBC, chronic infection indicator. And again, here HBE has converted to anti-HBE. And again, the DNA levels are almost high, increased liver enzymes. So again, this is an immune active phase. Now coming to the inactive phase, which can be either hepatitis E antigen negative, or this is actually a phase where hepatitis E antigen is negative, and here the anti-HBE antigen antibody has come. So here the hepatitis surface antigen is positive. We have the marker that is a total anti-HBC positive, and we have anti-HBE positive. And here you can see the DNA levels have started coming down, and even the enzymes have normalized. So this is an inactive chronic phase. So next, after this, according to the other factors, there is risk of reactivation to immune active phase, where the patient cirrhosis and hepatocellular carcinoma all develops. So the last is the occult infection. So in occult infection is a case where your HBS antigen is negative, and there are only what you can detect is the DNA, which can be detected in the serum. Even your enzyme levels remain normal. So this is a typical example of an occult infection. So these are the different phases in chronic infection, and how do you diagnose using the various serological markers. So now a few more points which we need to discuss was some atypical situations where we have some mutants. Two of the most common mutants are the pre-core mutants and the escape mutants. So in the pre-core mutants, there is mutation in the pre-core region which codes for the HBE antigen. So in such situations, you can see that the patient doesn't have an HBE antigen, but the HBS antigen is positive, liver enzymes all are elevated, the patient is symptomatic, whereas the patient, in that patient, you will not detect HBE antigen. So they are termed the pre-core mutant. They're usually diagnosed late, and usually during the chronic infection, they are diagnosed. Now, one more is the escape mutant, where there is mutation in the S gene as well. So that is why in such cases you cannot detect the HBsAg antigen. So again, this is a typical example where HBs antigen is negative. So such mutants are called escape mutants. And one more is a situation where post-vaccination, a person who is not infected, usually all the healthcare workers, they take the vaccination. So post-vaccination, the only marker which appears was it is anti-HBs. So this is post-vaccination. So now a little bit stress on the chronic HBV infection. So what does WHO say? The WHO outlines two strategies for HBV serological testing in a setting with HBsAg seroprevalence. So in a setting where you have a high HBsAg seroprevalence of more than 0.4%, a single serological assay is enough. So in settings where you have an existing laboratory testing is already available and accessible, laboratory-based immunoassays, mainly ELISA, CLIA, are recommended as a preferred assay format. In settings where there is limited access to laboratory testing, or in population where access to rapid testing would facilitate linkage to care and treatment, you can use the rapid diagnostic test. Now coming again to the serological testing, with a seroprevalence of more than 0.4%, if you have, then a single serological assay for detection of HBsAg antigen is recommended. Mostly in India, we have a 4% around serological prevalence, the seroprevalence. So that is why the detection of HBs antigen, you can use a single serological assay can be used. But if your prevalence is low, then you have to go for two different testing of hepatitis B surface antigen. Now, a little bit about the infants who are born to hepatitis B positive mothers. So in them, immediately after birth, we give the HB, that is the immunoglobulin, and the vaccine. So how do we test in infants born to these hepatitis B positive mothers? So there is the post-vaccination serological testing, that is PVST. It is recommended for infants and children who are born to hepatitis B infected mothers. So here the serological testing confirms whether the child has developed immunity or has been infected with the virus. So this testing should include actually hepatitis B surface antigen and also anti-HBs antibody. Usually anti-HBC are not recommended. PVST should occur the testing should occur between 9 to 12 months of age or 1 to 2 months after the vaccine series is completed, if the series is delayed. So again, tests for antibodies to hepatitis B core antigen, that is anti-HBC, should not be ordered, as there is that hepatitis B core antibodies are maternally transmitted from mother to the fetus. So that is, and these antibodies, they remain for nearly 2 years of their life. So testing of these antibodies doesn't give any value addition to your diagnosis. So that is why we insist upon only diagnosis by HBs antigen and anti-HBs antibody. So if the hepatitis B surface antigen is negative and anti-HBs is positive, that is antibody level is more than 10, it means the child is immune and no further workup is necessary. Now, suppose HBs antigen is negative and anti-HBs is negative, and even the antibody level after all your vaccination series is less than 10 milli international unit, then it shows that the child is still susceptible. HBsAg antigen positive, anti-HBs is negative with antibody level less than 10, it means that the child or infant is infected. Now, coming to the latest technology, that is genotyping and resistance testing. So globally, there is evidence that suggests that HBV genotypes, they influence the natural history, pathogenesis, and outcomes of the infection. So in particular, genotype C and D, there are altogether 10 genotypes in hepatitis B. So in that, the genotype C and D significantly increase the risk of progression to cirrhosis and hepatocellular carcinoma development as compared with genotypes A and B. While HBV genotypes, they influence response to interferon therapy, but they do not appear to significantly impact response to nucleoside therapy. In some of the studies which were conducted in India in 2019, they didn't show any pre-core or basal core mutants were not detected. Thus, routine HBV genotyping and resistance detection as part of clinical practice is still not yet warranted. Now, to summarize my talk, the various serological markers of HBV infection. So HBs antigen positivity indicates current HBV infection. If HBs antigen remains positive for more than 6 months, it is termed chronic infection. Presence of IgM anti-HBC implies recent or acute infection. And presence of anti-HBC, that is a total anti-HBC, it indicates, along with HBs AG positive, it indicates current HBV infection. And if it presents along with anti-HBs, it means that the patient is cured of infection. Anti-HBs indicates immunity against HBV infection, either because of prior cleared infection, if it is present along with anti-HBC, and if it immunized patients, you have only anti-HBs, no anti-HBC. HBe antigen, anti-HBe, and HBV DNA, they help in identifying the various phases in a patient with chronic hepatitis B. And for HBV screening, the 1 or 2 assay approach may be used depending on the seroprevalence in your area. So I wind up my talk. Thank you.
Thank you very much, Dr. Sangeeta. If I may be allowed to say, I have, being from the medical diagnostics field, there are a ton of questions here, right? And all linked because you have provided such an in-depth, how do I call it, analysis of the kind of diagnosis that can be done for hepatitis B. In fact, I've had a lot of requests. You would probably see them on the chat of people asking for your specific presentation. It's I would call it a super hit. In terms of information sharing, you've gone from A to Z and you've covered everything in between. So we'll hold on to the questions for now because we are on a little bit of a timeline here. And now I think it's time we move on to the next part of this particular panel discussion, which should go on to, prevalence of hepatitis B in a critical care setup. And well, you've covered pathology, you've covered epidemiology, you've covered the diagnosis, right? I think let's talk about actual prevalence in the critical care setup. And for that, I would like to invite Dr. Manaswita Biswas Agarwal. Ma'am, I will be sharing the screen on your behalf. So you can just tell me next whenever you want me to go to the next slide, right?
Yeah, so I will, first of all, very warm welcome to everyone. We have gained a lot of knowledge right now from the pathology part and the microbiology part. We are completely enriched right now. And listening to the previous two speakers, right now it is just a peanut-sized thing left, like just the application and what we are doing in the critical care setup, what is happening in the critical care setup. So my slides are not very elaborate. I would like to speak more than going into the slides. First of all, whenever we talk about hepatitis B on a clinical setup, when I go ahead with the slides, I will show you one slide. It is always said that the people who are at the major risk was previously for last 4 decades were mostly the surgeons, the people who are handling the internal organs or doing some kind of invasive procedures. But from last 4 decades, we have changed a lot. Our practice have become a lot more interventional right now. So now, right today, the people who are mostly affected with the hepatitis B virus, other than our patient pool, is the interventional people, which includes our critical care specialists, which includes our interventional radiologists, technologists, and so many. Okay, so this is just a brief about myself, that I work with the critical care setup in Apollo Hospital. I head one HQ, and very proudly I can say that in a year's time, I hardly get any hepatitis B or HIV positive nowadays. So that might be we are not getting critically ill patients into our, or we in Apollo are not getting them. Anyway, so
ma'am, I think yeah.
Yeah, can we move on to the next slide, please? Yeah, so discussion of hepatitis B in critical care setup is not an isolated topic. It is just are part of the broader horizon, which includes the risk of transmission of hepatitis B to all the healthcare workers, because that is also important. When you are serving somebody, you have to be safe yourself as well. And hepatitis B is one of the most prevalent transmissible diseases, because whenever we are handling infected patients, we are the ones who are at risk. And they, after we get exposed to that particular infection, there's a long course of surgery, there's a lot of struggles. So discussing this point, I thought would be a very different thing as a whole, because obviously it will be something which we usually don't discuss on, which we don't discuss on. So let's move on to the next slide. Next 3 slides will be a table where these are the published cases of healthcare workers to patient transmission. Like many a time, we are the carriers, we are not even aware that we have been pricked with a needle stick, and we carry the germ to a patient. And obviously, when we are practicing critical care, we are actually dealing with very ill patients, and those ill patients, they are at a greater risk of deteriorating if they are injected with a hepatitis B infection. On the other hand, we are always doing a lot of procedures every day. So many a times the patient is in the window period where they are not positive on report, but they are the carriers, and we get a needle stick prick accidentally and we get infected. So both ways it is very important. And these are the literatures which I could find. They were about the United, most of the studies have been done in United States. Back that time, India didn't have that much of publications or documents, but nowadays we are much better in documentation and there are a lot of publications happening. But somehow there are very less publication on HBsAg transmission from patient to healthcare workers. Very less. We'll move on to the next one. So these are the guidelines of management of hepatitis B infected healthcare workers. So these are given in country-wise. So there's a screening part, there's a vaccination part. But however, in India, what we are practicing currently, all healthcare workers, irrespective of the department you are working in, you are vaccinated and you have to get your boosters on time. This is actually a very, this guideline is a little bit older, which was started when the prevalence was understood among the healthcare workers from the patient pool or vice versa. So we can see if we take UK, so UK always had this in their screening. They had all it was mandatory for all healthcare workers who were performing EPPs, they have to do it post-vaccination. So vaccination was a must. In India, I think vaccination was much ahead of time for doctors and for mainly the medical practitioners who are the doctors. But for the other healthcare workers, we were not aware and we were not very strict on the guidelines on that part. But I think in near future, we will be having such a setup where all the people who are working in the healthcare sector would be vaccinated before they join their respective departments. Okay, so that was about screening and vaccination. On obviously, all healthcare workers need to get their booster dose from time to time. They shouldn't miss. I have had a colleague 6 months back who got a needle prick while doing a central venous catheterization, and then we found that the patient was hepatitis B positive, and that was really hasty time for my colleague. So it's not rare, it's still happening. It's just that we didn't document it day in and day out. So we can move to the next slide. So hepatitis B, as I already told you all, that hepatitis B is the most effectively transmissible of all the blood-borne viruses that are important in the healthcare settings. And healthcare workers are at risk of HBV from infected patients and infected are similarly at risk of transmitting HBV to patients or their co-workers. And this is very, very important. We need to be very, very careful, though it has decreased a lot after universal precautions, but it's still happening, and we need to be very, very careful. Even if it is a guided procedure, if it is a small procedure, bedside procedures, we are always, always, always at risk of acquiring this particular virus. We'll move on to the next. So the literature on transmission of HBV from infected patient to healthcare workers in critical care setup is really, really rare. I can hardly
Right. I believe we've experienced a little bit of a technical glitch, and Dr. Manisweta has dropped off. Please bear with us for a minute or two. I think she'll be back. We'll just have to reconnect her. Give us a minute, please. Sorry for the inconvenience.
Yeah, sorry, I got disconnected. Okay, so what I was going through was literature on transmission of HBV from infected patients to healthcare workers. Surprisingly, after working for so many years in critical care, we have really been lazy, that we have never pointed out that thing, and we have never documented it, but it's still happening. And there, at least in India, there are very less literature, almost no literature. One reason might be that we are busy with so many things around, that we are busy with COVID, we are busy with the new viruses, we are busy with dengue right now, that we have forgotten a very important infection, very important virus in our clinical setting. And also we are very confident right now that we have universal precautions. So we are double glovesing, we are using all the precautions, especially after COVID. We have been using all the precautions day in and day out. We are wearing the PPTs and PPEs and all. So that's why might be we are getting a little bit carried away. But hepatitis B is still existing in our clinical setup. Especially we can every other patient in our critical care setup is sick, and many a times we find them to be hepatitis B positive, along with maybe other immunocompromised state, or maybe in a case of a CA and all that. So we really need to get that on our notes right now, that we should not ignore a very prevalent thing, because it is not eradicated completely, and there is a lot more way of getting it transmitted, because our speakers have already spoken that how it gets transmitted in the community. And whenever the community people comes to a hospital, to a critical care setup or a medicine setup, they are actually exposing the healthcare workers to this, and in a way we are actually all getting infected in the single row. And we should be really, really, really concerned about this fact that we can't forget a very important disease in the process of learning about new diseases. So that is all. So there is very less literature. There's almost no literature, at least in Indian setting. I found few European literatures, but those were also a decade old, where the studies, and one literature of Denmark was done. That ended, there was a study specifically on critical care patients acquiring HBV, and that ended. Their latest study guideline is up to 2018. It has not been updated after that. And obviously after COVID we need to look into it, because many a times we find a COVID patient with a super added infection, or they are at a much more risk of getting a hepatitis B if they get it transmitted through us, through health workers, obviously. So we'll move on to the next slide. So the incidence of transmission of that's what I was talking about, that if there is a zero, like if the patient is in the window period, like we are not aware of the patient's like antigen is negative, but the patient is a carrier. So there's an incidence of transmission is in a antigen negative blood is 2%, and that becomes 19% in a positive blood. However, the transmission has decreased over the last 4 decades substantially because of universal precaution, but it's not nil yet. However, it's always better to be safe than sorry by implementing the guidelines properly to save both our critically ill patient as well as the health workers from this infection, which is very much lacking, because I'm into a lot of teaching the healthcare workers, and whenever I see my staffs working, since I head the HQ, I have to be very concerned about their health as well. So I see they're very reluctant. They're like, the patient comes in, they just do a IV cannulation without wearing a gloves. They're not aware how important it is to have that universal precaution. I feel now it is already told that you can't segregate a patient to be an HIV or a HBsAg, but you have to take every patient to be positive, and you have to think in that way. So like, we doctors are very concerned. Maybe we are the ones who are conscious about the fact, but it is not only us. We have to teach our paramedics, we have to teach our nurses, we have to teach our ward boys, we have to teach everyone that every patient, every new patient who comes inside our settings and we are delivering them service, we should be careful. We have to take everyone as a positive HIV, we have to take everyone as a positive HBsAg, and take all the precautions and then go ahead and do the thing, because we have already learned from our previous 2 speakers what are the hazards of having an HBsAg. And another thing I want to add here, that my mother, I lost my mother to HCC, that is hepatocellular carcinoma. And during that time, I was reading a lot about hepatitis and all, because obviously I was very shocked because she never had a fatty liver as well. And then the doctor from ILBS Delhi, he told me that he asked a very very weird history, that did your mother have hepatitis ever? So then obviously my grandparents were not there, so we have to dug some history from our uncles and aunts, and then we came to know that once in childhood my mother suffered from hepatitis, and he told me that even a cured hepatitis may give like what I can say, a poking to the cancer genes, and that person may have a HCC in future. So that is also very important. It's not a light thing. Okay, fine, I get it and I get treated and all. No, it's not like that. You may trigger your other genes to you may become may pick up some other bigger disease by just acquiring an accidental HBsAg. So that is one thing I wanted to add. This is a very personal experience that has nothing to do with this like discussion. So I think I'm done with all my slides. It's the last slide is left only, and that's a thank you to all of you for having me over this talks. The other 2 speakers were very elaborate, and since I'm in a clinical background, so I thought let me put some input of our clinical knowledge to it and what we face, because obviously in critical care setup, when we are working with critically ill patients, we are thinking about a lot of things, but we are missing on the smaller things which we should be very careful about. Many a times we get our microbiologists call us, many a times we get our pathologists call us and give us a direction, okay, this is happening. So we are just not taking that thing into consideration. Nowadays, what I see in major hospitals, serology is not a preliminary thing to do when the patient lands in the hospital. It is only done when case of surgeries. But before that, a lot of people are getting exposed. Before that, a lot of patients are getting exposed. So I thought that is the best way I can like put my input from the clinical background. So thank you very much for having me today over here. And I'm open for the questions now. Let's discuss about the topic.
Thank you, Dr. Biswas Agrawal. Dr. Zubair Hasan, Dr. Katie Sangeeta. Well, we have at the very outset, let me say thank you to a very big thank you to the three of you. You have taken a subject which is, been done to death, let me put it that way, in terms of hepatitis B. You've opened up, I think, a few eyes and ears here in terms of not just the basics of the disease, but the diagnosis, and as Dr. Agarwal brought in a real world scenario to what actually happens in critical care units, where things are, as you call it, you lose attention, you stop paying attention for a while, and we Indians are guilty of this even in the COVID scenario, right? You come out of one wave and we just wait for the next one to come and hit us. Hepatitis B, unfortunately, has been here for a longer time than COVID. It is probably claimed a whole lot more in terms of fatalities when it comes as compared to COVID-19. But we have learned more from COVID-19, I guess, than we have from decades of hepatitis suffering. Now, I would love to take up questions, but I guess we're out of time. And, there are a lot of questions which I will ask our Ms. Rituja Roy to get in touch with you and probably send you a small email, probably get your questions answered, and we will write back and communicate with the participants to the answers of their questions. I know some of those questions sound basic, but I'm sure every question deserves an answer. So we at JMitra make that commitment. We will do that exercise with our panelists here and ensure that the questions are answered, right? Ma'am, let me say thank you to all three of you, and while we will get the certificates delivered to you in person, for now, please accept our thank you. Dr. Hasan, sorry, I have this on Dr. Sangeeta, and of course, with Dr. Biswas, you had the shortest, how do I call it, the shortest talk time, but you also had the maximum impact, in my opinion, because yours was a real world scenario, and there is nothing that beats education which comes from real world examples. So thank you all so very much for joining us today. And, I'm really glad we all got this thing off together. So I look forward to collaborating with the three of you in the future again on some other topic. So thank you so much for your time and effort, all three. Thank you. From all of us at JMitra, thank you very much. We will be hosting our next webinar on the 24th of this month, which is a panel discussion on wheat-related disorders and mental health. Thank you.
Thank you.